Thank you very much, Juliana. Thank you to all the organizers of today. I think it's really an outstanding event, and I'm just delighted to be here. We did hear the term cerebral palsy phenotype earlier, and this is roughly the direction I'd like to go in my presentation over the next few minutes, but I'd like to move fairly quickly and not go over my time. So, of the three components that might contribute to the phenotype, we've seen this attempt in what James Rice called a binary system of going through the limbs and identifying the involvement and coming up with yes-no answers, which is entirely a logical and sensible way to approach things. The surgical definition of dystonia, as opposed to the medical one, of course, is that you do an operation for a child with cerebral palsy who has spasticity. They're instantly made very much worse, and you say, that was dystonia. There are several definitions, and this one has appeared before, but this is Terry Sanger and colleagues from the NIH task force. And I had the opportunity of seeing them at work at the end of a meeting when they were practicing some of their techniques for evaluating patients, and in the course of that work coming up with this definition. Dystonia, defined as a disorder in which involuntary or sustained muscle contractions cause sustained twisting, movements, postures, or both, now reached 481 citations. However, it's not really quite as simple as that, because as I observed watching Terry and his colleagues at work, I came to this conclusion that if you have a child with cerebral palsy and a complex movement disorder examined by a group of distinguished experts, 3 pediatric neurologists, 3 developmental pediatricians, 3 specialists in pediatric rehabilitation, 3 physiotherapists, they will come up with 42 combinations of movement disorder and topographical distributions. So the agreement between these is not easy, and I'm so grateful to Morgan for taking on this enormous challenge, and I think his work really has outstanding promise in terms of the sensitivity that we might need to measure the effects of medications which have effects and side effects, and that works across the whole spectrum. I chose the title A Moving Target because some of the work that we've done based on the wonderful Victorian Cerebral Palsy Register has enabled us to encapsulate concepts related to musculoskeletal pathology and other issues that we would never have done otherwise. This is contributed to by many people over many years, including Fiona Dobson's PhD, which focused on the subgroup with hemiplegia. Most of the data on classification on the kids who are ambulant with diplegia comes from the Gate Lab, and some comes from work by a master's student on the non-ambulant kids when we were chiefly looking at both hip displacement and scoliosis. So in 2005, based on the historical data, as James referred to, that had been gathered from charts and submitted from a wide variety of sources, that was the breakdown of movement disorders that we saw and that had been collected and that were reported. And it matches fairly well international data and large studies from Sweden and elsewhere. As we put together the work from Fiona, from the Gate Lab, and from Sun Jiang, this is kind of what we came up with, applying as best we could the task force definitions for movement disorders. So why the changes? Well, the hypotonia decreased. We particularly concentrated on those that had changed, and that might be delayed myelination, because you can't really have hypertonia until you reach a certain stage of maturation. The prevalence of ataxia was low and did not change, and we were able to re-examine most of those kids as teenagers. Hypertonia in younger children was pretty much uniformly diagnosed as spasticity, but in recent years, and due to events like this, there is now a much increased awareness of dystonia. I've still got a real question as to whether the movement disorder does change, and hence my question to James earlier. Does it emerge? It certainly, in later childhood, certainly varies enormously in severity throughout the child's growth and development. And is spastic dystonia a valid classification? So there's the comparison between the data in 2005 and how it looks to us currently. In complete contrast, gross GMFCS and motor classification seems relatively simple and relatively good agreement and relatively stable. As we looked at some of those teenagers, the title of my talk was deliberately a pun, because dystonia is a movement disorder, but it is actually very moving to meet and see some of the difficulties these young people have. And congratulations to Kirsty and colleagues for those excellent videos which could be used to educate us all, because this is not an easy and it's often a confronting disorder to many. So here's a young man with hemiplegia. When he was about 3 years old, he was classified on the cerebral palsy register as having a right spastic hemiplegia. His functional status was described as mild. When we saw him at 16, he was an angry young man who agreed to stay for a couple of photographs but not to go to the gait lab for a video. Oh. I'm sorry, I do apologize. Thank you, Morgan, for rescuing me. I'll try to look at the other screen. And this is the reason why. As he had got older, his involvement had become much more severe, and it's purely dystonia affecting his upper and lower limb, so that as soon as he lets his hand go, his arm flies out sideways, and it's a complete embarrassment to him, to the point that he asks, would an amputation be preferable? And he now uses a crutch in his left hand, but still remains probably as GMFCS2. In the severely involved young adults that we looked at for the monitoring of spine and hip disorders, we saw this. In the proximal limb segments, particularly at the elbows and knees, shoulders and hips were harder, but at elbows and knees, we could still detect in the majority of young people some degree of responsiveness to the speed of stretch, despite the presence of contractures. But when we looked at distal limb segments, particularly fingers and toes, we could see dystonia at work. And the only thing that can produce an alteration in the position of the great toe...
Your attention, please. Your attention, please. Emergency alarm testing will take place over the next 60 seconds.
Sounds like the Children's Hospital on a Friday morning during gait lab reporting. But only dystonia can do that to your big toe. And it doesn't matter whether the pathology is a contracture or a hip displacement or a scoliosis. This is kind of a very simplistic orthopedic view of where these things might come from. And as we looked at the two sides of the equation, and this is where I just again pay tribute to the VCPR and the ability to look at a population, it seemed to us that it's the negative features in the children with spasticity that predict hip displacement and predict scoliosis. But perhaps not so in dystonia, where if we were to put dystonia into the movement disorder, perhaps it is the positive issues of the dystonic movement pattern that may have something to do with the development, particularly of contractures, but not so much with respect to the bony problems of hip displacement and scoliosis. So I just want to very briefly present one clinical patient to give you a little bit of an insight into this interaction between movement disorder and musculoskeletal contractures. This is a delightful teenager with a right-sided involvement, unilateral cerebral palsy, and it's entirely dystonic in the upper limb and mostly dystonic in the lower limb. And she has this clinical appearance, and this is her standing X-ray, which is actually something that we absolutely never see in children with spastic hemiplegia. It's a disorder mostly of the midfoot and dystonia of muscles that we would never see involved with spasticity, the short plantar muscles in the foot itself, rather than the gastroc And this kind of problem crops up all of the time in dystonia, where something that looks like a pattern that you might see in hemiplegia and quickly dismiss as standard toe walking equinus is actually, on further closer inspection, something quite different. So, knowing that we were going to need to do some surgical intervention, we started with oral baclofen. This young lady is a very bright student and doesn't like what baclofen does to her thinking and cognitive functioning. We consulted with our colleagues in VPRS and asked for help in case we provoked a dystonic storm. We injected the short plantar muscles with botulinum toxin under anesthesia. We lengthened the plantar fascia. We lengthened a little bit the gastrocsoleus. That then triggered a complete dystonic crisis in the upper limb by operating in the lower limb, which was incredibly distressful, painful, and difficult to watch, and leading to the need for that unusual intervention, emergency Botox. And the pain and the spasms and the distress were really marked from a relatively small and simple intervention. This is where the lengthening occurred, and this is really completely distinct and different to what one would see in spastic hemiplegia. In addition to the muscle problems, she had a first MTP fusion of the great toe for a severe bunion. And although we achieved some improvements in foot placement, the correction was not to our satisfaction and not as ideal as we would have liked because of these profound differences between toe walking in dystonia and toe walking in spasticity. A couple of weeks ago in clinic, I met this delightful young lady who had called in for a quick visit for hip surveillance on her way to the combined clinic for assessment for an intrathecal baclofen pump. 8 years old, GMFCS level 4, wonderfully supported by the parents, you could see sitting anxiously in the background. FMS 211, purely dystonic movement disorder, presented for hip surveillance. She has bilateral but mild, moderate hip dysplasia, not needing intervention just yet. Being assessed for ITB, careful clinical examination, no contractures anywhere. Not anything was short. Not at the hip, not at the knee, not at the ankle, not in the upper limb. So that's a complete conundrum, and as Juliana said, more questions, not so many answers. Why do some get fixed deformities, and why do others not? So GMFCS, not movement disorder, predicts the bony problems of hip displacement and scoliosis, but contractures seem to be quite different. They seem to only occur in the affected limbs. In some children, there is very rapid progression and recurrence after surgical intervention, and other children do not develop contractures at all. And I'm hoping that with further study, including the kind of work that Morgan and Melissa are embarking on, that we might be able to identify those at risk and therefore prevent contractures. Maybe it's alternating flexor and extensor patterns. I'm going to stop there because I've gone well over time, and I thank you for your kind attention.